Good morning. Today, in honor of the World TB Day, which is on the 24th of March, we'll be talking about tuberculosis. And the theme for the World Health Day is Investors to End TB, Save Lives. Thank you, Dr. Abideen, for coming on the program. It's a pleasure to have you with us.
Thank you for having me.
Now, as a specialist, I know we're going to dive deeply into TB, but I just wanted to say how fascinated I am with the TB bacillus. It's a disease, it's a condition that has existed from the beginning of time. It used to be called consumption. People have died of it. The actual bacteria was actually discovered in 1882, as far back as 1882. This World Health Day started in 1982, 100 years afterwards. But today, in the 2000s, we are still battling to control the disease. So can you tell us what exactly is tuberculosis and why is tuberculosis still so prevalent in Nigeria?
Yes, tuberculosis is a bacterial infection caused by a bacterium called Mycobacterium tuberculosis. Basically, first affects the lungs, from where most times it then begins to spread all over. A lot of people in this part of the world, in the developing world, tend to get exposed to it. We're good enough, we're able to contain it. So we have what we call the latent tuberculosis, meaning it is there, but the body has contained it. For whatever reason, once the immunity is down, the tuberculosis finds its way and takes over. Like you said, at some point it was called the consumptive disease. At some point it was even called destroyed lung disease, because what is noticed is that it takes over the entire lung and just eats it up, destroys it completely. So apart from affecting the lungs, it could affect other parts of the body. It could go to the brain, it could affect the eyes, it could affect the heart, it could affect the kidneys, it could affect the intestine, it could even affect the urinary tract all the way, and it could even affect the skin. So I agree with you that it's a very fascinating disease. In terms of the control, from my experience, I would, one side, I would blame it on man. Our approach has been more or less that we tend to individualize the disease. A patient who comes in with tuberculosis, we reduce that patient to the disease. All we want to treat is the disease. The disease and a patient is more than that combination. There are people who they interact with. The patient who comes in got it from somebody. The patient you are seeing must have given it to somebody. Now, we typically take our eyes off the ball, not looking for where the patient got it from or who might have been exposed to it. So this means the disease tends to linger on in the shadows, even when we treat the index patient that comes before us. So the other bit now is the emergence of the HIV. HIV, since it broke out, tuberculosis has reemerged along with HIV. As we all know, HIV goes after the immunity. An individual who has latent tuberculosis and has HIV is likely to end up having an active disease coming up. So to my mind, these are some of the reasons why it has lingered on. And of course, I might add, poverty. It's a disease of squalor. It tends to move with wherever it is that there is poverty. Poverty would come with malnutrition, would come with low immunity, tuberculosis, and everything would come along with it.
Well, I think that's so important. And what you have highlighted is very interesting because it actually links directly into what we're talking about, invest to end TB. Because if you look at the amount of resources that were invested in COVID, in tracking, tracing, isolating, if that kind of dedication was actually put into TB, what do you think would happen?
For me, that would be the game changer. Each time I've had to have discussions with technical partners who are involved with combating HIV, I always highlight this point. Contact tracing is very key. I've had situations where, in fact, right now, if I could share that experience, I have a patient in my care somewhere now, a baby. By the time we did the contact tracing, the father had it, the mom had it, so the baby got it from the mom. In fact, we're having the multi-drug resistant type in that baby. If we had not traced, there was no way we would have known where it came from. So the likelihood is that we would have treated that child and that child would still come back to us.
No, I think it's so important. And those factors that you talked about are so prevalent in Nigeria, whether it's poverty, overcrowding, malnutrition. In fact, we are like almost like a textbook case. Would you say tuberculosis, Nigeria is one of the countries that has the highest level of tuberculosis now in the world? Or where are we ranking now?
Absolutely. We're ranking very high. In fact, about 30 countries are responsible for 87% of the cases we're seeing globally. Nigeria ranks very highly. We're in the top 3 on that rank.
And that's quite scary because of our huge population and overcrowding in the dwellings, in the cars, taxis, buses, you name it, all over the place. The risk then of the spread is so high. So can you tell us, how does tuberculosis spread?
Yes, very good question. This is where it becomes very important that as part of the prevention strategies, we always talk about education and awareness. So this education and awareness is for everybody. So people who are exposed, you have to come in very close contact with the individual who has tuberculosis, who is coughing actively. So an individual has a latent tuberculosis, as I explained earlier, the body has contained it. Some may come with tuberculosis of the bone. That's unlikely to be spread. Droplets and another person who is in close contact with the droplets.
And you see, I think something also to highlight is that even though it's a disease of poverty, a lot of people don't realize it, but people of all social classes in Nigeria get it because we are all interlinked. So for example, if your driver is sitting in a car and he's coughing, albeit a few coughs, that cough is being circulated by the AC and you are also getting it, or your house help. So the close contact is not, oh, I have to be living in Ajegunle to get it. But actually, anybody who is close to you could have it. And that is so important that if you find anybody coughing, maybe you check the COVID test and it's not COVID. TB is something you want to be thinking about because it's so common in our environment. So you've talked about what causes tuberculosis. You've talked about the different kinds of tuberculosis, but who is at risk? I think this is what we're really talking about now. Who is at risk of getting tuberculosis?
Everybody is at risk. I mean, taking off from the statement you made just now about, even the affluent who are intertwined with people who are not so affluent, means everybody is actually at risk. But there are people who are at higher risk of contracting tuberculosis. For instance, you have an individual who is immunosuppressed for whatever reason. When I say immunosuppressed, I mean the immunity is already, beaten down. For instance, the individual has HIV, the individual has some form of cancer, the individual has COVID, the individual is on medication that is actually, suppressing the immunity. For instance, people use a lot of steroids in this part of the world. I mean, from experience as a family physician and health system specialist, I find that a lot of people tend to abuse a steroid that is very common in the market. In fact, it works like magic for pain. So people tend to use them a lot. Prednisolone, to be precise. It's a drug that is really, really abused. This drug actually would cause a suppression of immunity. Then you have another group of patients who are on some form of immunotherapy. We're treating them for cancers. So quite a number of those drugs actually suppress the immunity as well, apart from, say, the cancer itself that can actually suppress the immunity. Then you have those who are not living here in this part of the world. People who are, in quotes, we'll call them expatriates, people who travel in to this part of the world because they have never been exposed. For instance, I can bet that I have latent form of tuberculosis. I am not dangerous to anyone. I am. So an individual who comes from outside this environment is at a higher risk compared to myself that actually live here. And of course, the elderly, then people who have coexisting respiratory problems, people who have what we call COPD, chronic obstructive lung diseases, are at higher risk than people who smoke. So the way people present these days is such that as part of our screening measures, would seek to know if the individual is coughing for up to 2 weeks. But these days, if you are even coughing at all, we're interested in that cough. We're interested in any cough right now.
So can you tell us quickly the signs and symptoms of, you've mentioned cough.
Yes.
And I'm very glad you said any cough, because a lot of people also right now, because of COVID, they deny cough. And also they suppress cough. It's really funny. Find when people go, but they're actually coughing, but they're trying to make it, insignificant. So people don't turn around and say, have you got COVID or something?
Yes.
So it's something that they actually, they actually are working at suppressing. So we need to also be aware that even small coughs are something that we need to look at and actually work at diagnosing. So how do you diagnose TB?
Absolutely. We diagnose TB, we could through screening. When we say screening, we're just asking some basic questions around the symptoms. But probably I left this out when we were talking about why we think, TB might have lingered on over time. A lot of people who have tuberculosis, even when active, are asymptomatic. They show no symptom at all. Some present in some funny ways, such as just losing weight and nothing else. I remember treating a biker, and that's all he presented with, just weight loss, nothing else. And everything had been checked until we did a chest X-ray. Lo and behold, there's a very huge cavity in the upper, field of his lung. So weight loss, cough, that's from being asymptomatic to loss of appetite, being tired, then having fevers, typically would be worse at night. Then we have what we call night sweats. And now these night sweats should not be linked to power outages, whether there is power supply or not, whether the room is well aerated or not. The individual just sweats and does not have any explanation for the sweating, and typically would be at night. Then they could cough up blood. We call that hemoptysis. Just simple coughing of blood. These are markers of advanced disease. Then some would present with severe tiredness. They find it difficult to actually breathe. Unlike COVID, these symptoms take time before they emerge. Unlike COVID, that it would emerge within a week or less. Then, of course, if tuberculosis is now affecting other parts of the body, it would present with what may suggest an organ affectation. For instance, if you have affected the brain, the individual could have fever and begin to have headaches. If it has affected the kidney, the individual presents with difficulties with making urine. If it's affected the intestines, the individual could have issues with weight loss and swelling of the abdomen. If it's affected the bones or the joints, it could present with bone pains, joint pains. So then, of course, certain skin lesions as well. So you need a very high index of suspicion. So which means your history taking must be very, very directed, must be very focused.
Thank you very much, sir, for coming on the program to share your experience with us. Can you tell us, how did you find out you had tuberculosis?
All right. Thank you so much, ma. Like some few months ago, I discovered I was coughing severely, and and the cough was so intense that sometimes I cough and I feel pains in my chest and things like that. So I said I don't want to be doing a personal medication, that I should go to the hospital and make a little investigation of what is happening to me. So when I got to the general hospital at Bagada, I was I was taken care of. Then I was told what to do. I went to the doctor, and I was prescribed. They prescribed drugs for me and some tests. So when the result of this test came out, that was when I was told that it was a tuberculosis.
Okay. So once you found out you had tuberculosis, what treatment did you go through? And how long have you been on? Are you still on treatment now?
Sure, I'm still on treatment, man. I'm still
So,
on treatment. So when I got there, I was given some medication. I was told what to do before I start using the drug. So they gave me some instructions on how I'm going to be using the drugs, so that if I can follow those instructions, then the drugs will be effective and effectual for me, so that I'm going to recover as quick as possible.
and
So I
did
was
that
told
happen?
to. Yeah, it happens. It's even was it after a month, I feel so relieved. The drug really worked so fine that the recovery was so fast and speed.
Okay. And well, you've been told you have to continue it for a period of time. Do you understand why?
Yes. I was told it's going to be consistent for 6 months. So that's at some intervals I'll be doing some tests as well to know, or to know how the healing process is going on. And that's what I've been doing all this way as well.
Okay. Do you know who you got it from?
Yes, from I've forgotten mommy's name.
Don't worry, don't mention the name, but you know the person. Have you got
Sure.
invited that person to seek for treatment as well?
No. I never knew the person I got it from. But
Okay.
I discovered that when I was little, it has once happened to me then. I was so young and tender. Maybe I was 7 to 8 years. My late mom then took me to the hospital, did a lot of stress on that, and it went. Maybe they never treated it very well to the to
And it came
the
back again.
foundation. Exactly. That was why it now reoccurred again. So I was told
Okay.
now that this time that it has reoccurred, I need to be calm and treat it and let it go once and for all.
Okay. Thank you very much. Thank you for sharing with us. Dr. Abideen,
Yes, I'm
well,
back.
that's actually a very interesting story. So it looks as if he may have had TB in the past, become latent, and then it reemerged again as an adult. Can you tell us what's the difference between latent TB and TB? And is this kind of thing that he's describing, is it common?
Now, yeah, it is actually, I'll take the last one. It is actually very common. So a latent TB would mean the individual is exposed to the bacteria and the body is able to wall it off. It's not causing any problem. It's quite there. There is evidence from a test, one of the few tests that we do called the quantiferon TB test. We could actually tell that this individual has a latent tuberculosis. Unfortunately, the National TB program does not cover treatment for this, but physicians who know how to deal with it would go ahead and give some medication. It's instructive to state here that an individual who has latent tuberculosis cannot infect another. Typically, they don't have symptoms. They do not cough. Unlike an active tuberculosis, the disease is raging. So a few things can happen along the line. The individual may not have completed treatment, and the disease is quite there. That is not the same thing as latent. We don't describe it as latent. We describe that as being, on incomplete treatment. So the individual may be all right for years. Then there are another category of individuals. They completed the treatment and they are certified cured. However, years down the line, they could be reinfected. So we call it reinfection. So the individual gets exposed again and becomes reinfected. The fact that you had treatment, it does not confer immunity against having it. So that's very,
very
some of the cases
important.
that we have.
Thank you. That's actually very important. So he could have actually had incomplete treatment. He could have been reinfected, particularly since they didn't find the source. For all we know, his mother could be the source. It could be anybody in his family that is the source, or somebody close to them that could be the source. And he could have had that reinfection then, or even had reinfection from a third party. Now, I want to talk about vaccines, because everybody knows about vaccines now. Are there vaccines for tuberculosis? Do they work?
Well, the only available vaccine known is the BCG. Now, the BCG, thankfully, is part of our EPI. That's the expanded program on immunization. So it's expected that anybody born between any time from the late 70s till date should have had a BCG jab. It is just one jab. It is given as soon as the individual is born. It's one of the early immunizations that is given. It's given only once in a lifetime. The protection is not 100%, but it does protect individuals, particularly children. I need to stress that, particularly children, from developing severe forms of the disease.
Now, can I challenge that? Because I've seen in some places people advocating booster doses of BCG at age 6, at 15. Now, we still give the one dose. Do you think there's a place for advocating for booster doses of this vaccine, particularly considering the prevalence of TB in our society?
That might be a bit controversial on many levels. The way the human body responds to the doses is such that an individual who is given responds very rapidly, and the antibodies form very quickly. Now, we really cannot tell specifically when it drops. Then quite a number of studies have actually been done looking at adults. At least I've come across a couple of studies looking at adults who had BCG, and they actually found out that it's actually not really so helpful, particularly in the adult. So now it is expected that every child who has had it is protected for nothing less than 10 years.
I think so. For me, I think there's a lot to be said about it, because we're talking about investing to NTB. If we have a vaccine that doesn't particularly work, we've seen the world rush into action to get COVID vaccines. Every company producing a COVID vaccine until they find the COVID vaccines that actually work, particularly for A species or B species or whatever. So this is the time we want to actually call upon the powers that be, the companies that can produce vaccines, and especially us. We need to invest in producing vaccines to actually tackle some of the conditions, for example, TB, that actually affect us. It may just be the fact that it's not a problem in the Western world anymore. That's why they're not producing vaccines for it. But we, on our own, need to look and see, how do we develop more suitable vaccines that work for this condition. You've talked a lot about pulmonary TB or lung TB, but you did mention the fact that there are other kinds of tuberculosis, non-pulmonary TB, affecting different areas. And I will tell you that there was someone who was very close to us on this radio show who died, unfortunately, in his 30s of a non pulmonary TB. For a long time, he didn't have a diagnosis. And even when he had a diagnosis, he was not sharing that diagnosis. So we have issues of stigma, we have issues of knowledge, we have issues there of late diagnosis and the cutting short of a very young and promising life. So, can you tell us a bit more about the non-pulmonary TB and why do we people have such a low index of suspicion for it, and what more can be done to raise that awareness and raise the importance of treatment and reduce stigma?
So good we're talking about this because on a personal level, I've had issues, with quite a number of the programs, particularly, at the primary healthcare level, where the treatment for it is actually de-emphasized. So tuberculosis can actually move from the lungs, which typically will serve as the primary focus, could move to any part of the body. It could affect the brain. It could cause an abscess in the brain. It could affect the meninges, that's the covering of the brain and the spine, TB meningitis. It could affect the bone. It depends on which kind of the parts of the bone that it affects. Typically, if it's affecting the spine, it would affect the upper spines. It can affect the lower spines as well. When I say spine, I'm talking about the back bones. So such individuals will present with back pain, most often adduced to, stress, poor postures at work, you'll be lifting heavy stuff. It is even much worse in elderly people because they tend to, say it's related to age, like it's arthritis, until you take a closer look. So that's why most times when a young adult, like the individual you mentioned, comes back more than once, complaining about bone pain, you would have to look up beyond the ordinary by doing a couple of investigations. Unfortunately, some of the investigations may come back negative until it is too late. For instance, the disease would typically destroy the bones of the back such that it will cause a collapse. If that does not happen, the individual tends not to present most often until you get to that stage. By the time we're doing the x-rays or the MRIs or our CT scan, we're seeing the bone that is actually collapsing. Yes, correct, there is a lot of stigma. This is one of the reasons why people do not always present. These conditions are treatable. It's the only difference is just that it's the same drugs that we're going to use, but the duration of treatment tends to be a bit longer than the pulmonary tuberculosis. So typically we'll treat it for between 9 to about 12 months. And the good thing, before now, we would always add an injection called streptomycin, but the research has shown that people do well without streptomycin. And the tablets have now been compressed, unlike what we used to have before. The pill burden was a problem. We would calculate the number of tablets the individual would take based on weight. So you might find somebody taking between 16 to 32 tablets. So that's how we came up with the DOT strategy. The individual comes into the clinic, sits down before the health worker and swallows these drugs. But because the drugs now have been compressed, so you have one tablet that contains 4 different types of tablets. So you find individuals taking between 3 to about 6 tablets on a daily basis at once, so which is actually manageable. Again, it's dependent on weight. So the individual comes in, we'll teach them, we'll give them instructions, we give them short appointments, we give them weekly appointments to start off with. By the time we know that they are compliant, we tend to give them longer appointments. We see them monthly till they are completely treated and certified cured before we discharge.
Now, I think what you mentioned about the disease in the spine actually happened to an uncle of mine. And this is where I was speaking actually from experience when I had spoken about the fact that you have a driver who can pass the TB to you. In fact, my
Correct.
uncle was diagnosed with cancer. They come to say goodbye to him. They said he had a cancer of his spine, and because he was old, he was in early 70s, until one of his sons carried him to the UK, where they now made a diagnosis of POTS and treated him. And he lived for at least 15 more years in good health after that treatment. So it just goes to show that these things can take away life. But if properly diagnosed, properly managed, and people having a very high index of suspicion, particularly in our environment, it could be life saving.
That's
But
correct. Absolutely.
what about, you see, we're talking about stigma, and I need us to talk about it because even people I have known, I have recommended for treatment, you bring them back, you tell them, go and tell your relatives you have that you have this condition, bring them in for screening. The issue of stigma stops them from doing that. They don't even want to tell their parents they have it. They don't want to tell their spouses they have it. And so, how do we overcome the stigma? How do we, make that difference? Because you can't contract trace if people are actively, hiding the condition.
Yes. So the issue of stigma, like we spoke about the areas we need to invest, which is why this program is very important, which is why what a firm I'm consulting with now, ANADACH, what they're doing right now is they're working with private employers of labor to talk about TB, tuberculosis. The whole idea is to create awareness, to educate people so as to knock down the walls of stigma. Everybody tends to want to hide this. The stigma attached to tuberculosis is probably worse than the one you have with COVID. And you can imagine an individual who has both COVID and tuberculosis at the same time. The level of stigma is almost times two. So the key to breaking this down is still education and awareness. We have to get the patients to actually understand and buy their trust so that everybody around is carried along. Same for employers of labor, because what we tend to experience is that an individual who's working has tuberculosis, the employer is aware that this person is being treated for tuberculosis. The next thing is they sack them. It's a very common thing. They just let them go. So what we tend to do these days is we get the employers involved right from the outset. We explain to them. In fact, personally, I write out medical reports. I give detailed explanations to them, and such that by the time we're done treating, we give another note to the person to take to the employer to say that this person is cured and can resume. The last person I treated that way, after we treated 3 months, this guy was a dispatch rider. We gave him the letter and he was reabsorbed back into his organization. He was one of the unusual cases, but the experience is often that they get dismissed.
And of course, that's the worst thing for them, because even apart from the fact that they need to take the drugs, feeding is an issue. If they don't have adequate nutrition, what happens? And because I've actually seen that in someone I was assisting at a time. The food that the person eats, even while taking those medications, because those medications are very strong, is very important. How much emphasis is placed on things like food when you are treating people with TB?
Very, very good. Very good that you're highlighting this. So food, particularly high in protein, vitamins, is extremely important. However, we always want patients not to take, we advise patients not to take the drugs along with food. We prefer it taken on an empty stomach, because with that, the acid that is in the stomach tends to encourage absorption. So we tell them to take it early in the morning. If you've missed for that day, you have missed for that day. Do not worry, continue the next day. So after it's taken, a couple of minutes later, the individual can eat. The quality of what that individual is eating is very important. It's not enough that the person is eating. It's not, don't just fill space. You have to fill space with quality food, very high in protein.
Okay, how can TB, I think I just have two more questions for you. The first is, people are amazed that the person who we spoke about who had TB, the wife and children are unaffected, but it was a non-pulmonary tuberculosis. Could you explain again how this happens? Why is it that people with non-pulmonary TB are safer, quote unquote, than people with pulmonary TB?
Good. That is because the people with extrapulmonary tuberculosis do not cough. So they do not shed the droplets actively in the environment. So if it's in the spine, it's lodged there, it stays there, causes all the damage there. So in fact, sometimes you could have a secondary infection. That's another bacteria could actually jump in on the act, such that you find the person will come down with a what we call paraspinal abscess, would form pus that would track around the spine. In fact, yeah, the last case that I treated is a young lady, young fit lady. She was just having back pain. By the time we checked, L4, L5, that's the lower lumbar bones, had already collapsed. But she had other problems. She had weight loss. She was throwing up badly, so she couldn't even take any medication. And unfortunately, I have to highlight this, regrettably so, there's a lot of stigma even among health workers, because people tend to want to not touch patients who have tuberculosis. And from my experience, quite a number of times, the patient comes in, has tuberculosis, the admitting physicians typically will not want to touch. They would say, look, go and call the TB team. And this is where I get involved all the time. I tell them, look, just go ahead. It's not a big deal. We can actually treat. So it's even still, exists amongst health workers, not just, family members. So for people who have extrapulmonary tuberculosis, because they are not coughing actively, it's why they are safer. They do not share the droplets.
Thank you. And lastly, how can TB be prevented?
TB can be prevented with very, very cheap, minimalistic approach. Good nutrition, which would dovetail into good immunity, immunization, good aeration in the house, avoid overcrowding. These are things we tend to take for granted. So particularly in schools, I've had situations where students from schools actually come. And by the time we want to go back to those schools, they do not want to disclose. Then it is important for us to break that cycle, that whoever is on treatment, very, very important, whoever is on treatment must complete the drug. Adherence, even though yes, it's therapy, on the long run, it helps us break the cycle. It's part of how we protect other people around.
Do you have any last words for our listeners, Dr. Abideen?
Yes, sure. So the theme for this year is actually ACT, invest to end tuberculosis, save lives. Now, these investments have to be targeted. We have to be a bit more focused with our investments. We need to invest in education and awareness, the infection control, all our screening programs. We keep it very simple, nothing, at the top. The early diagnosis and treatment, immunization, prevention with drugs, then TB prevention, therapy, which we call IPT, particularly in people who have HIV. These are areas in which we actually need to invest. Thank you.
Thank you very much.